American Cancer Society. His name is Tyler Kratzer, and I'm so excited that he made himself available to be with us today. He is a descriptive epidemiologist, which to me sounds like the coolest job title ever, at the American Cancer Society in Atlanta, where he's an associate research scientist on the surveillance research team. And he's also the co-author of the annual Cancer Facts and Figures and Cancer Statistics article. So you have him to thank for those resources that I know our coalitions use time and again. He has published multiple articles related to cancer surveillance and has a lot of different research interests, which include cancer among American Indian and Alaska Native communities. So please join me in welcoming Tyler Kratzer. Thank you, Tyler, for being here.
Hey everybody, sorry about that. Can everybody
Hi.
see my screen?
Yeah, we can see it. Thanks, Tyler.
Excellent. All right. Thank you very much for that really kind introduction. I'm really happy to be here with you all. And I'm really excited to speak about cancer surveillance and colorectal cancer mortality. So just to give a brief outline for today's presentation, first I'll go over some basics of cancer surveillance, followed by colorectal cancer epidemiology. Then I will provide an overview of the current state of colorectal cancer in the United States with a focus on mortality. Finally, I'll provide a brief overview of some disparities in incidence screening and mortality by race and state. As a surveillance researcher, we accomplish a few main tasks. The first is compiling and disseminating current scientific information on cancer occurrence. So we use a few data sources to compile that data. All of our incidence data is based on high-quality data from population-based cancer registries in the National Cancer Institute's SEER program, and that's either alone or in combination with the CDC's National Program of Cancer Registries. And this comes in a customized data set that we receive from the North American Association of Central Cancer Registries. That data set covers almost 100% of the US population in recent data years. And NACERS is a standard setting umbrella organization. Mortality data are based on the underlying cause of death reported on death certificates as provided by the National Center for Health Statistics. In addition to reported incidence and mortality, we also estimate the cancer burden in the current year in collaboration with NCI, and we use NCI software products to calculate rates and quantify changes over time. I'll also be highlighting some colorectal cancer screening prevalence during our discussion today. These are based on survey data from the Centers for Disease Control and Prevention. National estimates are from the National Health Interview Survey, and state estimates are from the Behavioral Risk Factor Surveillance System. We disseminate this information in the form of scientific publications like Cancer Statistics 2025 and lay-friendly publications such as Cancer Facts and Figures 2025. All of the information I'll share today is from the ACS research publications that keep a pulse on colorectal cancer occurrence in the United States. And all of this can be found at cancer.org/statistics. We also disseminate information via our interactive website, the Cancer Statistics Center, where you can find and customize the specific data that you're looking for, from incidence, survival, mortality to risk factors and screening, including by state. And we'd really appreciate if you would check this out and let us know what you think of it. When viewing cancer surveillance statistics, there are a few important terms that merit some definition before I begin showing some data. The first is the cancer incidence rate, which is defined as the number of people who have a new diagnosis within a defined population in a specified time period. They are typically given as a count per 100,000 population and are adjusted to account for differences in age. As an example from Cancer Facts and Figures 2025, there were 455.6 cases per 100,000 people in the United States during 2017 to 2021. Another important term is the relative cancer survival rate. This shows whether a type of cancer shortens the expected lifespan. This metric compares survival of a group with cancer to that of a group without cancer. These groups are matched on age, race, and sex. This is also within a specified period of time, typically 5 years after diagnosis. For example, 64% of people diagnosed with colorectal cancer during 2014 to 2020 were alive 5 years after their diagnosis. Another term very important to this presentation is the cancer mortality rate, also known as the cancer death rate. Similar to incidence, this is also reported as the number of deaths per 100,000 people in a defined population. Importantly, the cancer death rate is not confined to people with cancer. It's a common misconception, but this rate includes all people in the population. As an example, the cancer death rate for Black women is the number of Black women who die from cancer out of every 100,000 in a population, not out of 100,000 Black women with cancer. Death rates are the best measure researchers use to track progress against cancer, and like incidence rates, they are age adjusted. There are a few reasons we age adjust, but what it boils down to is that you cannot reliably compare rates in two populations with different age distributions because the risk of cancer increases rapidly with age. This includes different years, different racial or ethnic groups, and different states. As an example, you wouldn't want to compare Maine or Florida to, say, Utah, as the crude rates would be drastically different due to age differences, not differences in underlying cancer risk. The second primary thing we do in surveillance research is project the number of new cancer cases and deaths expected each year. Shown here are the leading estimated sites of new cancer cases and deaths for 2025. These are modeled with consideration to state-level variation in sociodemographics, medical settings, and cancer screening behaviors, among other variables. The reason we project these is because cancer incidence and mortality data lags by 2 to 4 years behind the current year, and these estimates are an important resource for public health planning, advocacy, and research. We estimate there will be more than 2 million new cancer cases diagnosed in 2025, with more than 600,000 cancer deaths. We also identify and track emerging trends and inequalities, which are things that I will touch on later on in my presentation. So now I'm going to get into some of the basics of colorectal cancer epidemiology. This might be a review for a lot of you, but I just kind of want to, put it in here as a base for my presentation. The colon and the rectum, along with the anus, make up the large intestine, which is sometimes called the large bowel, which is highlighted in pink on this diagram. It is made up of the cecum on the left side of this diagram, followed by the ascending colon, transverse colon, descending colon, sigmoid colon, and finally the rectum. The colon can be further divided into the proximal or right-sided colon and the distal or left-sided colon. These are important for colorectal cancer epidemiology because these tumors have distinct differences in their development, detection, and treatment. Most colorectal cancers begin as a non-cancerous growth in the inner lining or mucosa of the colon or rectum. These polyps are common, and most do not become cancerous. Those that do progress typically do so growing very slowly, allowing for their detection and removal during colorectal cancer screening. Colorectal cancer is the third most commonly diagnosed cancer among men and women and ranks third and fourth in cancer deaths, respectively. More than half of colorectal cancers are attributable to modifiable risk factors such as smoking, an unhealthy diet, high alcohol consumption, and excess body weight. This chart shows the estimated proportion of cases attributable to each risk factor. They add up to more than 54% because some cancers are attributable to multiple risk factors. Additionally, a large proportion of colorectal cancer incidence and mortality is preventable through the receipt of regular screening and high-quality treatment. So now that we've gone over some surveillance and epidemiology information, let's dig into some of the data. This chart shows long-term trends in colorectal cancer mortality. Mortality rates have declined by 57% since 1970. But while my presentation today focuses on mortality, you cannot tell the story of mortality without discussing incidence. Not least because declines in mortality have primarily been due to declining incidence, which has declined by 49% since its peak in 1985. Declines in incidence are a result of changing patterns and risk factors, like reductions in smoking and increased use of anti-inflammatory drugs, as well as increased screening. Mortality declines have also been due to improved treatment. A common question is how much of the decline in mortality is due to each of these drivers. And according to a recent study published in JAMA Oncology, there were 940,000 colorectal cancer deaths averted from 1975 to 2020. 79% of those were due to prevention, such as reductions in smoking and screening, while 21% of the deaths averted were due to treatment advances. This slide shows colorectal cancer incidence and mortality side by side, this time with rates for males and females separated. One thing you'll notice here is that while rates are consistently higher among men, the patterns are strikingly similar. Because of rapid uptake in colonoscopy, which mostly prevents cancer, colorectal cancer incidence began to decline sharply beginning in 1998. Mortality declines accelerate a bit later than that. This is because mortality is not based on the diagnosis year, but instead the year in which a patient dies, which means there is inherently a lag between incidence and mortality trends. However, over the last decade, declines have slowed to 1% per year for incidence, and a bit more steeply for mortality because of the additional contribution of treatment advances. Trends like these are typically described in terms of their change per year. This does not mean that each year the mortality rate dropped by exactly 1.3% per year, but rather over the specified time period, in this case, the last 10 years of data from 2014 to 2023, the average change per year is 1.3%. Describing trends in this way allows for comparison to different time periods, as well as providing a statistical metric to determine if those changes are significant over the given time period. When we do see a change like this, it kind of sets off a light bulb that there might be something going on in the underlying data that merits investigation. In this case, there definitely is, and it's a crucial one. A really important reason for slowing mortality declines is that cancer incidence is increasing for people born after 1950. When we stratify incidence trends by age, as I show in this graph, it's immediately obvious that overall progress has masked increasing incidence in young adults, which is beginning to affect the overall trend. While rates decreased by 2.6% per year in those 65 and older over the past decade, they are increasing by about that same magnitude in people younger than 50, and by 0.4% per year in middle-aged people 50 to 64. Now you look at this and you're probably thinking, well, that 0.4% per year is a really small increase, but it follows a decreasing trend of 2% per year in the previous decade, which mirrors the trend in older adults. This abrupt change is because of what's called a birth cohort effect. Every subsequent generation born after about 1950 has higher and higher risk of colorectal cancer. And people in those first generations are aging into this middle age group and carrying that excess risk, which is lifting the rates. This birth cohort effect has caused a rapid shift in the leading causes of cancer death in people under 50. In the late 90s, colorectal cancer was the fourth most common type of cancer death in both men and women under 50, but today it's the leading cause of cancer death in men under 50 and ranks second in women after breast cancer. However, breast cancer does continue to lead by more than 2,000 deaths. Now, another question that we have following up on that is, have these changes been seen in mortality rates too? The answer is yes, but not to the same extent. This graph shows the same age stratifications, but this time highlighting mortality by age since 1970. After remaining stable among individuals ages 20 to 54 from 1993 to 2005, mortality rates have since been increasing by 1.1% per year. The beginning of this increase lags by about a decade behind incidence, which mirrors the lag that we saw earlier. Similarly, rates decline in ages 50 to 64 until 2019, after which they have also begun to increase. For those 65 and older, rates continue to decline by 2.3% per year. We also see this playing out in the number of cancer cases diagnosed each year. This year, we're expecting about 154,000 new cases of colorectal cancer in the US, and 44% of these will be in people younger than age 65, up from 27% in the mid-90s. 21,000 of these cases will be in people under 50, the equivalent of 58 new diagnoses every day, which is a lot for a type of cancer that used to be considered an old person's disease. Notably, we continue to expect two-thirds of deaths to be among individuals ages 65 and older. This is due to a couple of reasons. Firstly, this birth cohort trend is driven by left-sided tumors of the rectum and distal colon, which I mentioned earlier in my presentation. They are shown in yellow and orange here, each of which is increasing by 2% per year, versus a slight 0.3% per year increase for proximal tumors over the past decade. Now, why is this important? Well, because cancers of the rectum and distal colon are easier to prevent and to treat than those of the proximal colon. meaning patients survive longer after diagnosis with these tumors compared to proximal tumors. Secondly, there are inherent survival differences by age. Younger individuals tend to have fewer comorbidities, such as heart disease, and respond better to treatment. Therefore, treatment advances are more impactful for individuals who are younger. This is apparent when we look at differences for distant stage disease, where 22% of people younger than 50 were alive 5 years after diagnosis, compared to 10% in those 65 and older. Unfortunately, we can't explore cancer mortality rates by subsite, specifically colon versus rectum. This is largely due to decades of messaging that refers to both colon and rectum cancers as colon cancer. This is frankly because people just didn't want to hear about or say rectal or rectum. That included people here at ACS. However, this drives misclassification on death certificates. And to help combat this, we urge medical and public health professionals to not use colon as a catch-all term. This graph shows trends in stated diagnosis for colorectal cancer since the mid-1990s. Shown in orange is regional stage disease, in blue, localized stage disease, and in yellow, distant stage disease. Another reason for slowing declines in mortality is that the most common stage at diagnosis is now regional or stage 3 disease, up from 52% of diagnoses in the mid 2000s to 60%, or 3 in 5 patients in 2021. This is surprising given that 64% of Americans 45 and older reported being up to date for screening in 2021. But this figure highlights screening underutilization among people under age 55. Screening recommendations begin at age 45 and have since 2018 for American Cancer Society guidelines and 2021 for United States Preventive Services Task Force guidelines. However, in 2023, only 34% of people ages 45 to 49 and 51% of people ages 50 to 54 were up to date for screening. However, prevalence in 2023 for those ages 45 to 49 showcases a significant improvement over 2021, when only 20% of adults ages 45 to 49 were up to date. There are two primary ways people are screened for colorectal cancer: colonoscopy and stool testing, with a follow-up colonoscopy for those with a positive stool test. Stool testing is even more underutilized in younger adults who are initiating screening. Stool tests are a great way to increase uptake in people in their 40s and 50s who often have busy lives with careers and children. So now I'm shifting from talking about trends in mortality and to talking about racial disparities, another area of deep concern, but also an opportunity. Alaska Native people in dark blue have the highest colorectal cancer rates not only just in the US, but in the world. Both incidence and mortality rates are 2.5 to 3 times higher than in white people. Native Alaskans are also the only group without progress, as both incidence and mortality rates are stable in contrast with declines in of all other groups. Native Americans outside of Alaska have the second highest incidence and tie with Black individuals for the second highest mortality. The burden in Native people overall, and Alaskans in particular, is exacerbated by the steepest increase in early onset disease. Since the early 2000s, incidence rates among Alaska Native adults under 50 have doubled, and mortality has increased by 60%. There are many hypotheses for the high rates in Native Alaskans, including vitamin D deficiency and a diet high in smoked fish and marine mammals, and low in fruits, vegetables, and other fiber. But differences in established risk factors do not appear to explain this extraordinary burden. One opportunity to help diminish these disparities is with increased screening. Native, Asian, and Hispanic Americans have the lowest screening prevalence, 54 to 57%, compared to 64% in white and Black individuals. Notably, these groups also have the highest rates of stool testing, suggesting an opportunity for increased screening uptake by more emphasis on stool test as an alternative to colonoscopy in average risk people. It is important to note, however, that among people with a positive stool test, follow-up colonoscopy is extremely low. This follow-up is important, as a positive stool test does not tell the whole story, including the possibility of a false positive. Increasing access to endoscopic services and lowering barriers to care, such as distance to access to that care for Native Americans, is an important step towards reducing disparities. This figure shows screening prevalence by state in all adults 45 and older. Prevalence ranges from 55% in Puerto Rico and 57% in New Mexico and Wyoming to 71% in Connecticut and 69% in DC, Maryland, and Rhode Island. This figure showcases how low screening rates at ages 45 to 54 are in many states. If you look at the right side of this graph, where the highest prevalence is in the 55% range, and go back a slide where the lowest prevalence for all ages is in the 55% range. You really get a feel for how low screening uptake is in this age group. Screening rates are 50% or less in all but four states, DC and Puerto Rico. The highest and lowest states are similar, however, with Connecticut and Maryland having the highest screening rates, and Arizona and New Mexico the lowest. Interestingly, utilization in Puerto Rico is nearly identical overall and in this age group, despite Puerto Rico having the lowest overall prevalence. There are also significant disparities in colorectal cancer mortality by state, but these are related more to risk factor prevalence than screening prevalence. Mortality rates are highest in Mississippi, West Virginia, Kentucky, Oklahoma, and Arkansas, which are all states that have the highest burden of cigarette smoking. To summarize, continued mortality progress is confined to those ages 65 years and older. This is due to a birth cohort effect of increasing incidence in those born after 1950. There has also been a shift to more advanced disease, driven by low screening uptake in people under 55 years of age, who have rapidly increasing incidence. There are also stark disparities in incidence, mortality, and screening, particularly for Native American communities. Increased awareness and recommendations for stool testing are a useful tool to help boost screening in average risk populations. I'd like to thank all of our nation's cancer registrars, and I'd also like to thank all of you for being here today and listening to my presentation. Thank you.
Thank you, Tyler, so much. So much to take in. I was posting in the chat. Anybody have questions, please post them in the chat and we'll make sure that they get answered. Tyler, again, I just really appreciate your attention to detail, your easy approachability in all this as we plan for this. We did have one question. Let me find it and go back. Hold on. One question from a friend in Alaska. Do you think we see that 65 to 74 age group screening adherence due to Medicare?
It's certainly possible, yes. I mean, obviously, individuals when they hit 65 start having access to Medicare, and we have seen where that can help with adherence to screening
Okay.
guidelines.
Yeah, because I know, like, for instance, in my own family, my father began having polyps removed at a certain age, and then I was told, due to family history, I should have polyps removed, or I should start testing at an earlier time period because of that. Um, you mentioned your affinity or your interest in American Indian and Alaska Native. Do you feel as if like the education for family history and the importance of family history is any different than it would be in other communities? Like I would think that that community, perhaps more than ever, would have a stronger family history component to share with one another. But is there anything to be said there about education for those that might be early onset?
I think I think that education is important everywhere, right? And making sure that people know their personal risk and their own personal family history,
Mhm.
and that includes for populations with a higher risk, such as in Native Alaskans. Um, I think that's really important for everywhere, and especially in populations with higher risk.
Yeah. And I know that in my own family, it was s stomach cancer until we dug a little deeper and realized that in those days and age, it was not stomach cancer. It was actually colon cancer. So finding those kind of details out can be challenging at times. Okay, a question regarding insurance. Are the screening rates in states higher where Medicaid has been expanded generally, would you say?
I do not know the answer to that question,
Okay.
but I would be happy to follow up with this group
Okay.
because
Yeah.
I know that we have we've done quite a bit of research into the impacts of Medicaid expansion, and in general, it improves cancer outcomes.
Okay.
But I do not know specifically for colorectal cancer
Yep.
if it's higher.
Yeah. And now more than ever, right? As we see the Congress having a bill before them to decide about different Medicaid coverage options. So we'll make sure that as a follow-up to this presentation, we get that answer to y'all. Do you know if there's any studies on the Alaska Native population specifically to try to really address their rates and increasing incidence of colon cancer?
Yes, there's a lot of fabulous people, both in Alaska and around the U.S. Who are researching that. Um, there's two things. One, the Alaska Native population is relatively small, which can make studying this very high burden difficult. And but there's a lot of ongoing work and some wonderful people who are doing that work throughout the U.S.
Thanks, Tyler. And I saw Kate, our colleague here at ACS, put in the chat addressing colorectal cancer screening among Alaska Native peoples, a community and subject matter expert symposium.
Yes,
That's
yeah.
exciting.
And I just saw someone said they work closely with Diana Redwood, who is one of those wonderful people that I work with on a regular basis.
Oh, wonder. That's great. That's great. Thank you guys so much. Thank you so much. Yeah, because I know that, for those of us that are in the coalition community, we're taught to do health education, health awareness, systems change, policy change. And so when we look at the disparities that you just shared about mortality, trying to figure out from a policy perspective what might change is, again, perhaps answering without an official hat on, but what are your thoughts on what policies or systems could change within structures to increase or to decrease these disparities? Is it expanding access? Is it um, go ahead. You look like
Yeah,
yes.
I think it's twofold, right? I think that it's very important to increase education because you wouldn't expect that the access differences would be quite that drastic between the people who are in that 55 to 64 range who aren't quite eligible for Medicare yet, but and the much lower prevalence in people who are 45 to 49 and 50 to 54. So I think education is a big part of it. I also do think that stool testing is a very good tool for average risk people in those age groups and making sure that there's education and access to stool testing, making sure that insurance companies are covering those stool tests. Um, you know, because then you have many more people who are able to at least get that initial test. Now, the follow-up to that is you have to have access to endoscopic services.
Okay.
Because if you have a positive stool test, you need a follow-up colonoscopy. And so making sure that people are educated on that and that they have access to those endoscopic services, that I think that those two in combination, so education and increasing access to care, are
Mhm.
both really important tools that we have to fight these disparities.
Awesome. Thank you, Tyler. One more question, then we're going to go to breakouts. But, knowing that younger people have an increasing burden, and I know I just saw 2 days ago, perhaps, in national news an article about early onset colon cancer. Do you know if the American Cancer Society or the U.S. Preventive Services Task Force are planning on lowering the age guidelines for CRC screening?
What I can say is that we, both us here at ACS and the United States Preventive Services Task Force, we regularly revisit all of our screening guidelines. And if the data points to a benefit to lowering the screening age guidelines, then that will happen at
Okay.
some point. Whether it will happen for colorectal cancer screening dropping to age 40, I don't know. I wouldn't, I that is not recommended for average risk people at the moment.
Hmm.
But at some point, maybe it would. I don't know.
Hmm. Well, thank you so much, Tyler, for your presentation today. And a special thank you for highlighting the disparities that we're seeing in our colleagues from around the country and the states that they represent here as coalitions. So thank you so much.
Thank you for the time.
Yeah, we appreciate you.